Ladies and gentlemen, thank you for joining MPRO, Standardizing Heart Failure Education and Engaging Your Patients in the Standard webinar. Your host for today, Karen Herring, will begin.
Hello, everyone. This is Karen Herring with MPRO, Michigan's organization that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. This webinar is presented in a collaborative effort between the Lake Superior QUIN and the Great Plains QUIN, which includes the states of North Dakota, South Dakota, Nebraska, and Kansas. We are all working with organizations in our states in a community-based approach to reduce 30-day hospitalist readmission rate by bringing organizations together in communities to improve care transitions as people move across the continuum of care. Since heart failure is a top readmission diagnosis for patients in all our states, we are focusing a webinar series on heart failure. I would like to welcome you to part 3 of the series entitled Standardizing Heart Failure Education and Engaging Your Patients in the Standards. Because Medistar is providing continuing education credit for this presentation, we need to inform you that no commercial support or sponsorship has been received for this learning activity. Our speaker, Karen Bush, has disclosed an affiliation with Health Trust and with Self-Care Solutions. No products or services are endorsed by Medistar or any accrediting agency. And for CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. Before I introduce our speaker, I'll mention that all lines are muted during this webinar. However, after the presentation, we will have a time for question and answers. So please make a note of any questions that may come up as you listen. Or you may use the chat feature, which is on the right side of your screen. The slides for this presentation are available for download on the sign-in page for the event. Now I'd like to introduce our speaker, Karen Bush. Karen has over 25 years of experience in healthcare. She began her career as an ICU and ER nurse in both urban and rural settings. In 2003, she earned a master's in nursing from Saginaw Valley State University and became a board-certified family nurse practitioner. She has practiced as a primary care provider in the outpatient and inpatient arena with experience in hospice, hospital medicine, and long-term care. She recently worked for Covenant Healthcare, where her primary responsibility was to drive the development and implementation of the Transitions of Care initiative within the hospital while creating and functioning in the role of transition coach. She has also achieved a national certification in readmission prevention. Currently, she is employed with Health Trust as a director for clinical data solutions, where she assists hospitals to utilize data to identify opportunities to improve patient care. As the president of Self-Care Solutions, LLC, Karen continues to work to assist healthcare providers reach out to their patients with meaningful information and tools for self-management. Karen, I'll now turn it over to you.
Thank you, and welcome everyone. Good morning or good afternoon, depending on what time zone you're in. I'm very excited to be here. As they said, I did disclose there is no commercial sponsorship. I do have an affiliation with Health Trust and Self-Care Solutions. And for CME, CN credit, attendance, full session attendance and completion of the online evaluation is required. And the participant is responsible for determining educational activities acceptable to meet CE requirements to renew licensure in your state. So I won't go through that again. So essentially, I wanted to start by just giving a quick overview of some things related to transitions of care. I like Golden and Shire's definition, the movement of patients between one care setting or care provider and another. And initially, we really thought that it was just a hospital issue. However, the more we learn, the more we realize that it takes the entire healthcare system to be engaged in order to make a safe transition. So I'm going to quickly just review the Physician Consortium for Performance Improvement did propose accountability measures back in 2009 for care transitions. They talked about a reconciled med list, transition record with specific elements to help the transition and make sure that the receiving provider gets the correct information, a timely transmission of the transition record to facility or primary physician, and then a transition record with specified elements by discharged patients. And then finally, understanding of post-discharge care needed. And later on in the presentation, that's the main thing that we're going to focus on. But I did want to kind of go quickly through. There are some very good evidence-based models to improve transitions of care. There is the BOOST program, there's Project RED, there's CPI, Eric Coleman's model, and they all have some common characteristics that I think it is relevant to point out. The first one is ongoing contact with a designated individual. And then the next thing is in-person, telephonic, or practice-based interaction prior to and following discharge from the hospital. Patient caregiver education, including teach-back. Comprehensive discharge planning, timing-coordinated PCP follow-up. Medication reconciliation, facilitated access to community resources, an intense focus on effective provider-to-provider communication. And these seem to be common themes in every good transition program. And so when we started working at Covenant on our Transitions of Care program, we had some very specific goals after looking at all of the research. The first one was to enhance the current tools and assessments utilized by hospital to effectively evaluate, anticipate, and meet a patient's needs for post-discharge. The next one was to improve the communication flow with our community providers, increase patient satisfaction with discharge and transition experience, looking at the HCAHPS scores, and then reducing overall readmissions. And we started with the key diagnosis area of congestive heart failure and then later added CABG and AMI to our program for transitions of care. We did have some overall initiatives, and I'm not going to go into in-depth in these slides, but I wanted to provide them because I know they provide you guys copies of the slide presentation. And I think if you're trying to promote an overall transitions of care initiative in your hospital and you want some evidence that supports some of these initiatives, I think it's kind of helpful to have that. So I wanted to provide that for you. The first one obviously is the follow-up appointment. And the studies show that timely post-discharge follow-up does promote reduction in readmission. There's some recent research that shows that this is particularly helpful with your high-risk patients. So I do really encourage looking at some sort of system for ensuring that your patient has follow-up prior to discharge from the hospital, and that was part of our initiative, our overall initiative at Covenant. And then discharge summaries within 72 hours of discharge. The research done by Crippolini on this topic is really well done and well documented. And I think he has further research out even since 2007. But it was found that direct communication to receiving provider only occurs 3 to 20% of the time, and the discharge summary available at the first post-discharge appointment only occurs 12 to 34% of the time. So, providing the follow-up is important, the follow-up appointment, but ensuring that the person who's doing the follow-up has the right information to take care of the patient is critical to the follow-up appointment. So again, just wanted to give you some research to kind of support that. Med reconciliation, we could spend the whole hour on med reconciliation. My bottom line after doing med reconciliation pre and post discharge on over 1,000 patients in the transition coach role alone is that if it's not painful, you're not doing it right. It really is a cumbersome thing to do with patients, but it also really is vital for the patient's safe transition from hospital to home. And then teach back. It is a very good technique for communicating with your patients that ensures that they've understood what you're trying to convey to them. You really need to have that patient repeat back the information that's provided. And I think a lot of people look at teach back, and this is what it looks like. This is a real good model by Schillinger. I think a lot of people say, oh, yeah, I do that. But really, you've got to have somebody watch you do it. In our program, we actually had people who looked at and watched the nurses do the teach back, and that was very beneficial for the nurses. We actually had them go through it 3 times with a patient to make sure that they were using the teach back approach correctly. Because we're not just talking about listening to the patient, we're talking about listening to yourself. This is an evaluation of the teacher's ability to teach, not necessarily the patient's ability to learn. And so that was just the general overview of what our transitions of care program looked like at Covenant. That was the base that we thought that every patient should have when they came into the hospital and was discharged. And then what we did was we started looking at a transition coach role and did a lot of research and looked at what would be included in the role, how would we implement it, how would we track it, what tools would we use to document it. And at the end, I can answer any questions you might have on those topics. But essentially, I kind of wanted to just go through what is a transition coach, and I'm really hoping I don't look like this when I talk to patients. I'm hoping I look more like this when I talk to patients. But essentially, a transition in their own health so that they can safely transition from the hospital to the home setting. Typically, transition coaches start working with patients while they're in the hospital. And our program, we did face-to-face interaction with patients at bedside and started providing education. And then we followed them discharge, and it can be either telephonically or with home visits. I will say that our program was strictly a telephonic. We did phone calls. We did them within 72 hours of discharge, and then we did them weekly for 4 weeks initially, and then eventually we adjusted the intensity of the follow-up based on. So we did, our program evolved as we took on more patients. The target is to enhance the safety of the patient's transition, which results in a reduction in readmissions. One of the things I will say about our program is that we really did make sure that we had that engagement with the patient before they left the hospital. Every patient had a right to refuse the transition coach. We had very few patients that refused, and we did very well at capturing patients post-discharge. So the post-discharge interaction, I just wanted to talk a little bit about what's included in that interaction. We would review the disease state and comorbid conditions and talk about, management, what things to watch for, signs and symptoms to monitor and report to the physician. We did med reconciliation, and again, if it's not painful, you're not doing it right, we would ask the patients to get out all of their med bottles, and we would go through every single one of their medication bottles. Follow-up appointments, and again, you can ask the question, do you have your follow-up appointment? But the bigger question is, do you have transportation to your follow-up appointment? And if they don't, then we would tap into some community resources or family or somebody to help them get them to their appointment. Post-discharge services and community resources, has home health been out yet? All those types of things. How are they doing with the adjustment? Oftentimes, especially heart failure, if it's a new diagnosis, it can be very challenging for people to adjust. So we would spend some time talking to them about how are they doing with that adjustment. And then intervene if a patient arrives in the emergency department. Late in our program, we started doing this. We actually have a system where we have patients on a roll, and if they admit to the ER, as soon as they hit the ER door, it pops up to the top of our list that they're in the ER. So we would contact the ER doc and talk to them and let them know, what happened during their last discharge, what's happened since they've been discharged, the resources that they have at home to really try to make sure that that transition back into the ER is a good transition as well. So what a transition coach is not. We are not a primary care provider. Our goal is to get the patient to engage with their primary care provider in a meaningful way. So we really help them with rehearsing how are they going to talk to their doctor about some of the symptoms they're having. If they're having symptoms of depression, how do they talk to their doctor about that? Or what are they going to say about their weight and what they're doing? So really looking at trying to enhance that relationship. We are also not a discharge planner. It is a different role. You cannot lump transition coaches and discharge planning in the same. And we are also not the sole person responsible for readmissions. I do caution people, if you're going to look at doing a transition coach program or nurse navigator or whatever you want to call them, Just be careful that staff understand that this is a whole system approach, in that just because they have a transition coach doesn't mean that you don't have to provide the same education that you provide your every other patient. Sometimes things start to kind of fall by the wayside if you've got that coach there to support the education, and it's not to replace the education that nurses provide or the discharge planning that your discharge planners do. This is something to enhance those transition services on patients who are higher risk, a moderate to high risk. So that just goes a little bit over transition coaches. What are they? And like I said, I can answer more questions after. So when I started creating the program, I looked at a lot of research, and the challenge with educating patients in particular is that studies demonstrate that 40 to 80% of the medical information that patients receive is forgotten immediately. Half of the information that patients do retain is incorrect. And patients have negative feelings and emotions related to their limited reading ability or limited understanding. So they're really not comfortable telling us that they don't read well or they don't understand. And then they hide that with a variety of coping techniques. And so what ends up happening is most of our patients end up feeling like this. And so what I did was we looked at what we're teaching, how are we teaching it, what are we using to teach, and what's already available out there. And that's where we started. We started looking at our organization and looking for this information. So what we decided was that after looking at a lot of research and talking to educators, and I actually talked to people who teach in schools, the education needed to be interactive. The education had to flow across the continuum of care. So it was something that needed to be able to go from the hospital to the primary provider. We also noted that we had a lot of patients who readmitted with dehydration and acute kidney injury. And so we thought whatever we used to teach, it had to address the symptoms of fluid overload, but also address that potential for dehydration and acute kidney injury. And then we wanted to make sure that we had the opportunity to involve caregivers and family when we could. And so then what we looked at was what actually does the patient with heart failure really need to know and understand. So I looked at the different societies and I looked at what was out there, and generally speaking, people needed to understand what was their recommended activity level, what was their diet as far as their sodium restriction, fluid restriction where appropriate, discharge medication, follow-up appointments, weight monitoring, and what to do if signs or symptoms worsen. So that was what we targeted with our program. And then when I talked to staff and patients and outpatient providers, I talked to outpatient providers and said, hey, what are you using to teach your heart failure patients? What's out there to teach heart failure patients? There was no one tool for education that was consistently used. We had this giant cardiac book that we would give patients, and I would talk to the patients, so do you have your cardiac book? Oh, yeah, I've got 3 of them at home. Have you ever opened it? No. So giving people things is okay, but they've got to have something that's going to engage them. And they really didn't understand how to implement the instructions that they were given in their everyday life. So the patient knew, yeah, I have a 2-liter fluid restriction. How do you manage that? Well, I just don't drink a lot. Well, what's a lot? Well, I don't know. I just don't drink a lot. It wasn't, they understood what the instruction was. They knew they had to restrict their sodium. They just didn't get how to track it. They knew they had to weigh themselves every day, but they had no idea what they were supposed to do with the weight. I weigh myself every day. Well, what do you do with it? Well, I write it down. Well, do you do anything if you start gaining weight? No. So it was clear that what we were providing currently wasn't engaging the patient. Also, many patients had family who didn't understand their disease, and they would advise the patient. So the heart failure patient would start feeling bad, and they would start gaining weight, and they would develop a cough. And so they would be coughing, and their family would tell them, oh, maybe you're getting a cold. You probably need to eat some chicken soup. And, you might be getting dehydrated, so, maybe some Gatorade would help, that would help thin out your secretions so you can bring them up. Families will tell people interesting things, and because they don't necessarily know what the standard is and how to treat these diseases, very well-meaning family can tell patients the wrong things, and the patients will do those things. And again, our patients were readmitting with acute kidney injury and dehydration as much as they were with heart failure. So that was what brought on the impetus for me to develop this toolkit that I created. And it was an educational tool to meet the needs of the patient. And what we did was we created a prototype. I tried a couple different pieces out on some different patients just to see, do you think this might help you? And, they're like, yeah, this is great. And so we decided that we would create 50 of them and do a research study. So the last presentation, I kind of breezed over some of the research and some of the data because I wanted to get more into, what to do with the data and what data to collect. So this time I'm going to go into it a little more because I did get feedback that people wanted to see the data more. So we did a pre-test, intervention, post-test, and then a 30-day post-test. And we used the Self-Care of Heart Failure Index that Barb Riegel created, and this is a wonderful tool. It measures heart failure maintenance, management, and confidence with the use of the diagnosis-specific toolkit. That was what we were measuring. And when you looked at it, maintenance is like, do they weigh themselves every day? Do they attend their doctor's appointments regularly? Do they take their medicine? Management is what to do with the information. So if their weight goes up, do they know to call the doctor? And then confidence is their confidence with their ability to take care of themselves at home and that type of thing. So it's a good tool. I recommend it if you're doing any kind of research in the heart failure transitions area. I did the pre-test for baseline. The post-test was completed immediate post-intervention. And then we also mailed the post-test 30 days after discharge from the hospital because I wanted to know if the change that occurred in the hospital with the education was sustainable. And then, of course, the secondary aim was to reduce 30-day readmission rate. So we identified subjects for the study. We targeted heart failure patients with a primary working DRG of 291, 292, and 293. And I approached patients as they came. So I didn't filter out based on whether or not they were high readmission, low readmission. I just took them as they came that presented with primary DRGs and those working DRGs. We did have some exclusion criteria. If they went someplace other than home, because it was a self-management tool, we excluded them from the study. If they had renal failure and were on renal replacement therapy, so if they were on dialysis, we excluded them from the study. And if they had comorbid COPD with active treatment, because sometimes it was hard to tease out, is it COPD or is it CHF that caused the admission, so I was a little leery about that. And then kidney or heart transplant patients were eliminated from study. The study population, we targeted 50 patients. We actually lost 6 patients to study due to last minute after they got the toolkit transfer to skilled facility, or one patient transferred to hospice, declined and transferred to hospice. So there was a couple of patients in there that we lost. We did have 41 patients who completed all 3 surveys, so I had a return rate of 93%, which is pretty good. 34% were female, 66% were male, 29.5 had disposition home alone, 70.5 went home with family. 36.4% received education with a caregiver, and 63.6% received their education alone without a caregiver with them. So when you look at Barb Riegel's tool, a 70 or greater mean equals self-care adequacy, and more than half a standard deviation improvement is considered clinically relevant. 50th percentile marked reductions in odds of having an episode of hemodynamic congestion and risk of death or hospitalization, and 75th percentile was direct inpatient savings, cost savings were seen. So this is what the study ended up looking like. You can see on the pre-test, the blue is the maintenance, the red is management, and the orange is the confidence. Pre-test, they were all below 60%, and actually, immediate post-test, they were all above 70, and then 30-day post-test, they were sustained above 70. I did have a drop in the maintenance. However, it still was above the mean of 70, and the confidence actually improved. And so this was the hard numbers for those of you, I know everybody's going to copy this, so these are the hard numbers for the data and the p-values and standard deviations that are included. And so we did have some good feedback from patients. I always like numbers, but the feedback was also very beneficial. The toolkit works. I use it every day. I thought it was an excellent idea. Because we were at Ludington for several days with our families over Thanksgiving, I let my guard down and overindulged in fluid and salt. Because of the study and the toolkit, I realized something wasn't right. I got my act together and got back on schedule, which got me back to feeling better. So this is what we're talking about. This is engaging people in their health and using something that's hands-on to remind them that they need to stay on track. And, you know, I had one patient who, it was a subsequent patient. She was not in the study. But she was a subsequent patient that got a toolkit, and I was getting ready to discharge her, and I said, okay, you know, we're going to discharge you now. You're graduated from our transitional care program, because that's what we call it, graduation. And she said, before we get off the phone, I got to tell you a story. And I said, okay. And she said, I was at Gordon Foods the other day, and she said, I was at the checkout. And this was somebody who had severe cardiomyopathy, and so she had a life vest on. And the girl at checkout said, oh, you're a heart patient. And she said, yeah, you know, I got this life vest on. I got it. And she's like, no, you went to Covenant. And she said, well, how do you know I went to Covenant? She said, you got those beads. And she said, yeah. And she said, my dad has those beads, and they kept him out of the hospital for a year and a half. So that was pretty exciting that somebody would have that much value. The beads are one of the things in the toolkit that help them track their fluid. And so, which I'm patent pending on. So that's was kind of a neat story, but you can see it did impact patients, and it continues to impact patients. We get positive feedback frequently on not just the toolkit, but on the interaction with the transition coaches and how it benefits the patients and how they feel that it has helped them learn how to take care of themselves. So we did want to look at readmission data. So there were 44 patients in the study. 40 patients stayed out of the hospital for 30 days, 4 readmitted, which gave us a readmission rate of 9%. Our readmission rate for heart failure at that time was, I think it was 23% at the time that we were doing this work. The hospital purchased 100 more kits. They thought it was beneficial, and so I wanted to demonstrate that it didn't take a nurse practitioner to do this role and to work with patients using this kit. So I had this wonderful colleague, her name is Bonnie Hartwick, who is also a transition coach, and she helped me out, and she used the kits. We both went up and we started using the kits. Our first 41 patients, 37 patients stayed out of the hospital 30 days, 4 patients readmitted, so it was a readmission rate of 9.8%, which I felt fairly confident demonstrated that a nurse could use it just as well as a nurse practitioner, and it did not affect our readmission rates. So then, I'm a glutton for punishment, so I wanted to make absolutely sure that this tool is actually what's helping, and the transition coaches are actually making a difference in reducing the readmissions. So I looked at 255 heart failure patients. It was January, February, March, April. It was the first 3 months of the year. And I looked at where did they come from, and what was the impact of some of the things that we were doing. And so you can see that most of the patients, a lot of the talk around readmissions and heart failure is, oh, it's all those skilled facility patients. They all come in from that skilled facility. Well, I looked at the data, and actually there were very few patients. We only had 17 patients that came in as an admission for heart failure from a skilled facility. Now, this isn't looking at readmissions. This is a primary index admission, but chances are, if we only had 17 patients coming in as a primary diagnosis, we're not getting a lot of readmissions. And I did look at that at a later time in a later study, and it was patients coming from home more than patients coming from facilities. And so what I did was, at the time, we were working on a couple of different things, and I showed this last time, and I'm just going to go a little more deeply into the data this time. We looked at localizing our patients to one unit. So we were trying to get our patients on our PCCU unit and trying to focus the education and focus the care of those heart failure patients in one location. I will tell you that this really did make a difference for us. You can see that 57% of our patients, heart failure patients, ended up on our PCCU unit. 19.2% readmission rate of those patients. The patients that ended up on other units, there was 43% that ended up on other units, and the readmission rate for the other units was 25.7%. So clearly localizing patients was a benefit for our program. The other thing I wanted to look at was if they were on these units and they got a toolkit, did that make a difference? So the readmit rate for the patients who were on PCCU was 13.7 if they were on PCCU and they got a toolkit. If they were on another unit and they got a toolkit, the readmit rate was 17.2. So it did help. And this is the hard numbers so that you guys can take a look at those and see, you know, kind of where we fell in with the numbers. And then I looked at whether or not the intervention or not having any intervention or an intervention of a transition coach with and without a toolkit, what was the impact there? And so you can see that 23%, the blue bar, 23.5% got no intervention, and the readmit rate there was 33.3. And then 45.1% of the patients got a transition coach only with no toolkit. And that readmit rate was 23.5%. And then 31.4% got a toolkit and a coach, and the readmit rate was 12.5%. So from that, we decided as an organization, and oh, by the way, these are the hard numbers for that as well, so just so you can see what the actual data was. So from that, we decided that we wanted to expand the program. The hospital purchased 1,000 more kits to be used on all of our heart failure patients over the next fiscal year. That was a year ago, July. And they are still using the kit in the program. As a matter of fact, I just talked to one of the coaches today, and I think one of them's on the call, I hope. And we did implement it as a standard of care. The other thing I did want to point out is that we had a lot of MI patients with low EFs that were readmitting for heart failure. And so when we would sit down with them to give them the toolkit for heart failure, they would say to us, why didn't I get this when I was here with my heart attack if they knew that this was a problem? And I would say, well, that's a very good question. So we started absorbing MI patients into our program and eventually CABG patients. We implemented a system where the nurses on the nursing units actually put in a data point of what the patient's ejection fraction is. It's a data point in the cardiac assessment. We built it into Epic, and from that, we auto-generate a list every morning to our department of every patient in the hospital that has an EF of 50% or less. We review those patients to see if they're appropriate for a toolkit and a coach. And we have adjusted the intensity of our follow-up based on a LACE score because we have also implemented a LACE score in our program. So our program has expanded. Again, like I said, we purchased 1,000 more kits. We implement the toolkit for high-risk patients, LACE score greater than or equal to 10. At that time, we were manually calculating LACE scores. Now we have it built into our Epic system, and we're using the LACE Plus. So that is no longer the standard number that we're using. I want to say it's 70 now. With ejection fraction of less than 50%, diagnosis of AMI and CHF, and we have expanded to CABG. We implement the toolkit additionally on any other appropriate heart failure patient. We have a consult to transition coach. It's been added to our EPIC system, so any doctor or nurse in the hospital can consult us to review the patient's chart and evaluate for transition services. The toolkit is provided with video education, so I created a video because we couldn't run around and sit down with every patient and do all this education. So I created a 20-minute video that was uploaded into our LMS system, which is our patient education system. And so what we do is we set the toolkit up in front of the patient, we show them the video, and then we come back using teachback, we reinforce the education. The nurses are also very engaged, especially the nurses on those particular cardiac units. We now have 2 units that we localize all of our patients to our entire 3rd floor in the hospital. And the nurses are very engaged. They know the toolkit. You know, they have the patients practice monitoring their fluid with the beads that we have. You know, they make sure the patient understands what their weight is every day. So they're highly engaged as well. And then each patient will receive at least one post-discharge phone call within 72 hours of discharge by the transition team. And some of our higher risk patients receive more intense follow-up. Or if there's a red flag that comes up at that first call, then we might continue to call them for a couple of weeks. But that has allowed us to broaden. We've also added a 3rd transition coach to our program. So we now have 3 transition coaches who are working with our patients on the 3rd floor. So where is the hospital now? So how is our data looking? Well, according to Hospital Compare, the U.S. national rate of readmission for heart failure patients in 2014 was 23%. And the national rate of readmission for our hospital during the same time was 26.6%. So now, according to the most recently published Hospital Compare data, and I just pulled this down for this past posting year, the U.S. national rate of readmission for heart failure was 21.9%, and the rate of readmission for our hospital was 22.5%. We are now at national average. We were above national average. So the other thing I like to look at, because there's research out there that talks about the effect of HCAP scores and the correlation with readmission rate. There's a recent 2011 study that was released in the American Journal of Managed Care. It was William Bolding that did it, and a whole group of people with him. And what it showed was that overall patient satisfaction and satisfaction with discharge plan was associated with 30-day risk standardized readmission reductions. So just to kind of drive that home, I wanted to look at what were the readmission rates for those particular units that we were working on, if they didn't get a coach and if they did get a coach. And so these are the 6 questions that are covered in the discharge section. So there's the 3 that are the standard percentage, and then there's 3 that are the top box questions. So what I did was, you can see in blue are if the patient had a coach, and this is our PCBU unit. And if they had a coach, this is January 2016 through December of 2016, and we were using toolkits during that time and having coaches work with patients. You can see that the coach did much better with the discharge HCAP scores than just having them with a standard care in the unit. And most of the time, well, on this particular unit, we were above the statewide average in all 6 question areas. On TCCU, again, you can see that the coach had some better HCAP scores than just having the patient on the unit alone. And we were pretty close to state. We went above on a couple of them, and then we were just below on a couple of other ones. So, and then all payer reason for readmission, heart failure. So I looked at the data from Readmetrics, and this was back in 2015. And you can see the green line is the all group, and then the blue line is covenant and you can see in 2013 was when we initially started. I started in May of 2013 at Covenant. 2014 was when we really were kind of up and running with our readmission initiative, coaches, and we did the research study in July to December of 2014. And you can see where our readmissions for same diagnosis of heart failure have dropped dramatically below the all group. So we did pretty good there. So just to give you a little summary of the lessons learned, having a hands-on toolkit that can follow patients across the continuum of care is helping us to improve self-care and reduce readmissions. And just so you know, this didn't happen in isolation. I went out and I presented this toolkit to our physician hospital organization, our primary care providers in the community. I would stop docs in the hall and give my 2-minute elevator speech. When I did the research study, I actually faxed a copy of the toolkit and the research study to the primary care provider who was receiving the patient in the community so that they would have an idea of what the patient was doing. We encourage our patients to take they have a system for weighing themselves and writing it down. We encourage them to take their of how to use the toolkit, and we encourage them to take that to their primary care appointments so that this truly can follow the patient across the care continuum. And it really has made an impact, especially we've even had patients who, and I know some of our southern states where they have, or tourist areas where they're taking care of these patients and then, they're snowbirds, they're going back to Michigan. So how are we going to follow them then? Again, this was something that we created that was hands-on, that could follow that patient back to their primary care doc no matter where they were. We would call them, reinforce the education no matter what state they were in, and encourage them to take it to their doctor's appointment so that they could follow up and make sure they were taken care of. We also noted that the transition coach, either nurse practitioner or RN, is effective in reducing readmissions on patients with home disposition and are even more effective when a hands-on tool can be used. And then localizing patients to one unit was beneficial in reducing readmissions in our heart failure population. We really did see a benefit with that. I thought that was very valuable. And I will tell you that the staff become very engaged in the heart failure care of the patient when you're localizing them to one unit instead of having them spread all over your hospital. These were some of the resources that I used in creating this presentation. And then this is a final thought. When I started doing transitions of care, I found this quote, and I thought it was so relevant, and it really did, I always came back to it. In the space between chaos and shape, there was another chance. Patients, when they're being discharged from the hospital, as soon as we say discharge, their mind is home. They're thinking about the bills they got to pay, the things they got to catch up on, the laundry they got to do, whatever. They are not thinking about learning and understanding. So the value of having something that they get early in their hospitalization that can be reinforced during their hospitalization helps to provide clarity for them to continue to follow when they get home. Hands-on with reminders. I encourage you, if you're going to create something like this, do it something that's hands-on with reminders that can really help patients engage with it, and then also help their families engage with it. Keep it simple so that their families can engage as well. But it is chaos. But in that space between chaos and shape, there is another chance, and I encourage you to reach out and look for some of those different opportunities to create clarity in the chaos for your patients, because it is possible to do it, and it does benefit not everyone, but it will benefit a lot of your patients. So this is my contact information. Again, I don't think it got communicated the last presentation, so I wanted to make sure you guys had it with this presentation, and I'm happy to take any questions that anyone might have on anything that you might want to know more about.
Thank you very much, Karen. We now have time for questions or comments for Karen. Katina, will you please remind our participants how to get in the queue for questions or comments?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And ladies, I'm waiting for people to join the queue at this present time. Okay, so our first question is going to come from Diane. Please go ahead.
Yes, I have 2 questions. What department do the transitional care RNs work under? And then is there a certain amount, like you said you had 3 transition coaches, is there a certain amount of patient load that they work with?
Yeah. Well, our transition coaches report up through the quality department. And we average about 50 patients, and sometimes we go over. I mean, sometimes you do what you got to do to take care of patients. We all do it, but we average about 50 patients, per coach.
Okay, thank you.
Mm-hmm.
And before we take the next question, Webex, will you pull the evaluation, please? If you could take a moment to fill this out, we would greatly appreciate it.
Our next question is going to come from Laura Brio. Please go ahead.
Hi, yes, 2 questions. One in regards to the evaluation. Where do we access that from?
I don't have the answer to that. I think
Actually, our apologies. You will get the evaluation when you close out of the webinar. It will pop up on a separate screen. Our apologies for the question.
Okay, well, wonderful. Main question then is that toolbox. Is that accessible to people outside the Covenant system?
Okay, so in my disclosure, I put that I am actually the president of Self-Care Solutions. It is my company. I own all the copyright and the patent to the toolkit. So if you email me, or if you would like to go on my website, you can see what's in the toolkit. It's self-care, www.selfcare.net. And so if you want to reach out to me, I can give you more information on that.
Okay, that'd be great. I'm a new transition coach, and any tips and hints I can get for educating my patients consistently would be wonderful.
Yeah, no, that's fine. Just shoot me an email, and I can help you out with that. But if you want to see the toolkit, selfcaresolutions.net. The toolkit's on there, and the research is on there, and how to get in touch with me is on there as well too.
Okay, selfcaresolutions.net.
Yep.
Okay, thank you.
Mm-hmm.
Our next question is going to come from Beth Egan. Please go ahead.
Hi, I was wondering, I thought I heard mentioned earlier that you would be sending out the PowerPoint. I was not able to visually log in, but certainly listened audibly to the presentation. Is that true? You'll be sending out the PowerPoint?
So a recording of today's event will be available on our YouTube page, the Lake Superior Quinn YouTube page, in the next week or so. If you are able to get into the sign-in page for the webinar, the slides are also available for download there.
Did I answer your question, Beth? Oh, she's gone. All right, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Ladies, I don't see anyone in queue at this present time. Oh, we have one from Ann Barton. One moment. Please go ahead, Ms. Barton. Ms. Barton?
Yes, I'm sorry.
I'm sorry, but I don't see where the access to the slides are. Hello? Hello?
Ms. Barton, I can hear you. Yes.
Okay. I've signed in, but I don't see where the access to the slides are.
They should be in the bottom left corner under event materials.
Bottom left corner. On the event info tab? Where? I don't see them.
If you want to put your email in the chat, we can send them later.
Okay, thank you.
Our next question is going to come from Audrey Anderson. Please go ahead.
Hi, this question is for Karen. Very nice work, Karen. I'd like to know how long the transition coach followed the patient.
We follow the patient for 30 days. After 30 days, we graduate them. Unless something comes up on that last call. There's always that caveat. If something comes up on the last call, then we might hang on to them a little while longer just because, they're up, 3 pounds and we told them to call the doctor and we want to make sure that they're trending back down before we let go of them. But for the most part, 30 days is what we keep them for.
Okay, thank you.
Our next question is going to come from Anastasia Rokas. Please go ahead.
Yes, I was wondering, has this toolkit been pushed to any insurance carriers at this point to see if they can utilize it?
No, I have not. Again, I work a full-time job, and no, it has not. I think it would. I think there's a value there. But no, I haven't gone down that avenue yet.
Okay. Well, thank you. It was very good to see all those results.
Sure.
Again, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Okay, we have 2 more questions in queue. Our next question is going to come from Darlene Tuma. Please go ahead.
I'm just wondering, the toolkit, is that available to us?
It is. I own it.
Okay.
So if you want to go on my website or shoot me an email, I can give you information about it. But I own all the copyright and the patent.
Okay.
So, yeah.
All right. Thanks. Thanks.
That's okay.
Okay. Our next question is going to come from Susan Barre. Please go ahead.
Yes, I was wondering, do you work with any long-term care providers? We do post-acute rehab, at facilities?
We have had patients who have gotten the toolkit and it followed them to long-term care, and then we followed them after they went home. So what we did was we would tell the patient, okay, well, you've got the toolkit, so now you know how to take care of yourself. And when you get home, eventually, after you have your short stay, because we all know it's not long-term care anymore. So after you have your stay, give us a call, and we usually follow up with them as well and make sure that they've got it. They make sure they understand how to use it, reinforce it. So we have had that. I did have one nursing home group that is looking to pilot, and they've purchased a few kits for pilot to see. Their challenge at this particular facility was getting the right patient to engage with it. So I'm not sure what the barrier is there, and I haven't circled back with them recently to see if they're having any more luck with it. In the hospital, this is what you need to do, and, it's a little more, but in the skilled facility, I used to work skilled facilities, so it's more your home setting, and so it's a little more difficult to say, you have to do this, because, they have their rights to do what and in the hospital, I think it's a little more directed. But I do think there's value there, and I think, if you found the right approach to it, I actually, last time I talked to the facility, I talked to them about maybe engaging their physicians to get them on board with it, to try to get them to help support, the patient.
Interested in, I'm also in Michigan, just a little southeast Michigan, but would you be interested in piling with another facility in Michigan?
Sure.
All right, I'm going to email you my contact information and maybe we can talk.
Okay, sounds good.
Okay, thank you.
Mm-hmm.
My next question is going to come from Rebecca. Please go ahead. From the internet?
Yes, I'm just currently looking online at the toolkit that has been put together by Karen, and I'm noticing the balancing beads. Are those something kind of like a prayer chain, or how does that work?
Yeah, that's actually what I own the patent on, is that those beads and that system for tracking fluid.
That's one of the biggest things when I'm doing the education of, we have like a 1 liter fluid water pitcher at the bedside, and if they're on 2 liters or less, and just how to engage the patient in actually measuring what it is that their fluid volume is in a day.
Yeah, so the water pitcher thing and the 2 liter pop bottle that they can keep on their counter at home is great, except that our patients are mobile. They're not little old ladies that stay home that are going to just dump water out of a 2 liter bottle or fluid out of a 2 liter bottle every time they drink something. And so I came up with this system that was how the whole toolkit started. I came up with the system. I figured out how to put the beads together. I did the color coding on the beads so that they knew when the caution was and when the stop was. And that was the first piece I started using with patients, and I was like, holy mackerel, this works. And
okay.
So that was what prompted me to go further, and I started working with our Office of Innovation at Covenant, which is now closed. But I started working with them, and they were like, this is a great idea. And I'm like, well, I got more. And so that was how the kit came about, was me sitting at home trying to figure out how to get a patient to understand what a 2 liter fluid restriction was. And the other thing that I think is important is we use the beads not just to tell them you need to drink under this amount. We also use the beads to tell them you should be drinking at least, so we tell them you should be using at least 6 beads a day, but you don't go over 8 beads a day. And that's your fluid, because we don't want them to get dehydrated.
Correct.
And then we adjust, the beads based on, so we tell them if they've got a 1.5 liter fluid restriction, we tell them start with 2 beads pulled down. So, but yeah, that's the piece, that is my patent.
So then, Karen, if we want to get one of these kits, we just contact you and send you a check? Is that how it goes?
Yep.
And how much is a kit?
Well, it depends on how many you want, and if you're interested in a pilot with a certain amount of kits, then I can reduce the price. But the price per kit is $60 a kit.
Okay, thank you. Thank you very much. Enjoyed your presentation very much. Thank you.
Thank you. Thank you.
We have one more person in queue at this time. Sylvia Hennon, please go ahead.
Yes, I was just wondering, real quick again, from the time you implemented the toolkit to the time of the end of your study, how much did you reduce readmissions by again?
Overall readmissions for CHF was reduced during the time of the study. I think we had like a 2% reduction in heart failure readmissions during this. But we were not working with every heart failure patient that was walking in the door at that time. The toolkit we had 50 toolkits. But we had a readmission rate with the toolkit of 9%, while the hospital's readmission rate for heart failure was 23%. So the impact on overall readmissions during that time frame is hard because we only had 50 of the patients that were admitted with heart failure during that time frame.
Mm-hmm. And then how much since then has it reduced?
Well, the combination of, and I always say, I don't take full credit because we have a lot of different things going on to reduce readmission. So again, we were localizing patients to one unit. We were using transition coaches, and we were implementing the toolkit. So with all of those things in place, we've had a year-over-year reduction of almost 2% each year.
Okay. Thank you.
With all of those. So that's why I say that was why I took the extra step of looking at January, February, March, and April of 2015 to see the different interventions and how they were impacting our readmissions, because I wanted to make sure what actually was working, and was it just the toolkit, or was it just the transition coach, or was it just localizing patients, or did the combination make a difference? So that was why I took the extra step to kind of look at that. But since we've implemented transition coaches, we have progressively reduced our readmissions in heart failure overall.
Thank you.
Mm-hmm.
This concludes this educational session. Thank you again, Karen Bush, for speaking with us today. The next webinar in this heart failure series is supporting CHF patients in the home setting through a comprehensive community approach on Tuesday, September 26th, 11 a.m. to 12 p.m. Central and 12 p.m. to 1 p.m. Eastern. Before you close out today, please complete the survey that will pop up when the webinar ends. We appreciate your feedback on today's session. Once you have completed that evaluation, you will receive a certificate of completion. Please make sure that everyone on your team that has participated in this webinar receives a copy of the certificate. This session was recorded and will be available on the Lake Superior Quinn and Great Plains Quinn websites in about 2 weeks. Thank you all for participating.